it's a good segue into our next speaker, because you talked about actually the power of big databases, actually, and how critical that was to informing the work that you do. And so our next speaker is Dr. Mark Hoffman, who is the director at the Center for Health Insights at University of Missouri, Kansas City. I think Dr. Hoffman has a long experience at Cerner prior to coming to University of Missouri, Kansas City, and he's going to be talking about biobanking and big data. And I was aiming some of my questions at you about the electronic health record.
I'll see how many of those I can incorporate into my... like many of us, I'll try to adjust a little bit in reaction to some of the discussion today. So I want to share a little bit about my background. As an undergraduate in molecular biology at William Jill, I was in a program that included, as part of the curriculum, overseas study at Oxford in bioethics. So it was really important to me as I progressed in my career to incorporate the ethical concerns. Then as a graduate student in molecular biology at the University of Wisconsin, about in my third year, I realized that I really want to be an engineer, not a scientist, and so that I really like to build things. And so part of the theme in my comments will be that from the systems perspective, from the architecture perspective, if nothing else, I hope to equip the group to have a deeper discussion about what is big data, because just like genomics 15 years ago, the term was utilized to mean just about anything involving DNA. Now we're seeing the same effect with big data. So if nothing else, I hope that my comments will help equip us to discuss big data. But also, I think there's a perspective in the informatics community that there's a potential harm of not merging data. In the public health world, there's literature that HIPAA kills people because it's overinterpreted and slows down the pace of research. And the elephant in the room, we're next door to the KU translational research. Translational research is about accelerating research. So, there is a tension between discussion that might, do we slow things down, or do we put on the brakes, or do we hit the gas pedal, and how do we strike the right balance? So my hope is that from the data perspective, we can get into that. I'll have modest comments about biobanking, but I think we'll talk about how that all relates. So first of all, the challenging topic, what is big data? So first of all, I'll say it's more than a lot of little data. That might seem obvious, but when I ask people, what do you mean by big data? They say, it's big. Well, what else do you mean by that? It's really big. And so, I think part of the discussion needs to be what really is big data. So it is difficult to pin this down. So some people talk about how they're using data. So search engines, social networks, banking and finance. People working in these areas will all say, in genomics, will all say we're doing big data. Other people use a size-based definition. So if they're working with data that won't fit on their laptop, it's big data. So, sometimes there is no formal threshold, terabytes, petabytes, when do you become big data? And then probably not so much relevant to this community, but in the engineering world, it's also defined by what technologies you're using. So if you're using an Oracle database versus new technologies called MapReduce and HBase and Hadoop, especially, is a really fun one to say. If you say Hadoop in the big data world, you're halfway in, so just as a tip. So some people will use a technology-based definition for what is big data. But this is probably maybe the most important slide I'll share today. So if nothing else, these will give you some things to have a deeper discussion of what is big data. These are 4 attributes that are utilized in discussions of big data. So the first is volume. So you do need large loads of data. There's no formal number for what those thresholds are, but it absolutely has to involve probably not hundreds of patients, but hundreds of thousands of patients. Probably not single genomes, but multiple genomes. So there is a volume aspect. The velocity is the second aspect. So data at rest is a term that you'll hear often in data discussions. I think the example that, this is a little bit challenging for us, but census. How often does the census happen? Every 10 years. So that does not have velocity because the census is not a frequent sampling of data. Whereas financial transactions, banking transactions, social networking transactions, those have very high velocity, and designing analytical tools and techniques that can keep up with that velocity is a big part of the challenge in the big data world. Variety is the third aspect of big data. So if you're talking about a very narrowly constrained and defined data set, even if it's a really large data set, it may or may not really be useful to apply some of the techniques to big data. So a registry, for example, it has 20 questions that you ask a group of patients. You might have a lot of patients reflected in that, but the variety of the data is narrow. But when you start to merge a registry with genomic data or biospecimen data or a larger set of clinical data, then you're really starting to hit the variety threshold. And then in an ethics group, the fourth attribute that's incorporated is called veracity, mostly because they need four things that start with the V. So veracity in the data sense is different than truthfulness and honesty that we might have in the ethics world. But what we mean by veracity in the data world is that it can be traced back to its origin at the time at which it was captured. So when you have rapidly moving data, there's this versioning is probably maybe a better term. So let's say that you have a nursing form. Today it has 4 questions. So I know that I'll have 4 of those data points today. A month from now, we add 2 more questions. The version of the form has changed. So now we have the potential for 6 data points, but 2 of those data points will be missing from the earlier data set. If you don't design your big data analytics to accommodate that fluctuation, your statistics will be thrown off, your analysis will be thrown off, and the veracity of the data might be confusing. So these are 4 characteristics of big data that I think are important to add to our toolkit. So my background comes from I spent 16 years in the electronic health record environment. And I think, there's the view that, meaningful use, the movement towards adoptions of health records start to get lost in the means versus the ends. We're focused very much on the means right now, but the end is capturing discrete data that lends itself to analytical purposes. We've spent a lot of time, talking about privacy. I think we do need to remind ourselves of the alternative that, just a few days ago I was walking through a clinic and could have taken this exact picture of paper folders. Anybody can pull one out, thumb through it. So, privacy is, I don't think necessarily harmed or helped by this, but I think you made the comment earlier. I think in many ways it is helped because you have audit trails, you have a much deeper level of rigor around the security around information. So overall, I think EHRs actually help with privacy, but they also create a very robust data set. So I'm just going to give 3 brief illustrations of things that we've worked on that are only possible at the big data scale. So this first example relates to disease surveillance. In 2009, there was an anticipated flu pandemic. It wasn't quite as severe as anybody thought, but the CEO of Cerner, Neil Patterson, had a conversation with Secretary Sebelius about what can we do to help during this anticipated flu crisis. And through that, there was an outreach process to the entire client base. And in 3 months, we created a system connecting 800 non-affiliated institutions in 49 states for the purposes of assisting them with their flu surveillance. By connecting those sites and processing millions of encounters per day, we were able to provide the participants with access to maps and graphical data showing what's happening locally to them. This is compared to the CDC was only able to provide updates every 2 weeks. So by connecting this high velocity data in a manner that benefited every participant, I think it was a win-win. There's also using de-identified large-scale data sets derived from patient encounters. This is an example of some work that we performed on therapeutic drug monitoring. So when you combine laboratory results, medication orders on the large scale, you can identify institutions that might be an outlier, and that can then inform process quality improvements at those institutions. So one of the examples that we did was related to digoxin levels and lithium levels. So the organization represented by the gold bar, for their digoxin levels, their patients fit in the median of the composite group, which comprised 73 facilities merging their data. But that same organization, for their lithium levels, was an outlier. So when you think about taking that back to those organizations and saying, you should probably evaluate, how you're prescribing lithium, how you're monitoring those patients. So when you start to get to these large-scale analytics, you have the opportunities to do new things. The third example is the traditional method of querying data would be, I'm curious, this is related to C. diff infections. So thousands of people die each year from C. diff infections. And let's say that the traditional approach would be, I'd like to know whether or not, it's pretty obvious that immune function would correlate. If you have reduced immune function, you're at higher risk of C. diff. So you would design a query to ask that specific question. In the big data world, you can just look for correlations across the entire data set and sort and filter those towards things that have positive and negative correlations with any outcome that you're interested in. And so again, this is only possible by merging large data sets. And then some brief comments on biobanking. So most places have what I would categorize as a biorepository. And not to be derogatory, but generally the thought is samples go in, but they don't come out. And so that's, people have donated their samples to support large-scale analysis, but often those are hoarded and very possessive. Whereas a biobank, they're treated as assets to be utilized for the benefit of patients and for research. And so a biobank has the ability to query the information about the samples, ideally reaching towards the correlation between genotype and phenotype. There's also bank-like functions, so check in, check out of samples, making sure that you don't deplete more than you actually have, and things like that are some of the functions with a biobank. So when you merge a specimen repository with phenotype data in the electronic health record and genotype data, such as that being collected at Children's Mercy and other places, and then put the ability to query that, that's a local biobank. And then when you have multiple biobanks and you add the ability to do federated queries, then you start to really reach the opportunity to ask some very novel research questions. My view from the technology perspective is there's very few technology barriers, but the political barriers to implementing this are, I've actually shifted my energy to other areas just because I think even a federated model, everybody's moved away from thinking that you just put all your freezers in one place and have a big biobank, but implementing the federated model is still a very challenging topic. I think there is some feasibility, but it is very daunting. But what can you do with that if you can reach that point is when you combine derived clinical process information other than that specified in the record. So for example, there's proxies like Benadryl prescription can be a proxy for an allergic reaction. So there's things that you can infer. And then if you want to look at the genetics of adverse drug reactions, you can pull the records for patients who had Benadryl prescribed and then start to query their genetics. So the phenotype to the genotype and vice versa from the sample to the genotype and then to the phenotype. So to wrap up, I think, I think there's a lot of topics that have already surfaced today related to sample sharing policies, intellectual property, privacy. I think the unique topics related to big data that warrant a few further iterations are, given the nature of big data, the needle in the haystack aspect to it, how do we know what to believe, what not to believe? Machine learning, the math behind all of this is impossible for any single person to comprehend on their own, and so you really have to trust the statistics and the math. And so how do you make sure that that level of trust is there in the data? And I think one of the many analogies that comes to mind is drinking from the fire hose. And so, that's really where we're at with big data. I thought there was probably just a slight chance that the Henrietta Lacks book wouldn't come up, but the other reference that is very accessible on big data is the book shown here by Shannon Burger, and it's a very good coverage of some of these topics. And with that, I'll stop.
Great. So I don't think Mark answered my question, but I'll get back to it. Okay.